the last session, myeloma, was focused on immuno-oncology. We talked about CAR T cells there, and I've gone over the details of CAR T cells. In addition to CAR T cells, there was a couple of other interesting presentations. One very interesting presentation, which the myeloma community has been waiting for a very long time, was the role of checkpoint blockade in multiple myeloma. What was done at this oral session at ASCO was the FDA actually presented their data of their understanding and their information on both the KEYNOTE trials. The KEYNOTE trials were two. One was in the upfront setting, the other one was in the relapse setting. Upfront was lenalidomide with pembrolizumab versus Lendex alone. The relapse was Pom-Dex versus Pom-Dex Pembro. And what was noted and what was quite remarkable was after about 150, 160 patients accrued on this trial, there was increased toxicity noted, and with that there was an increased association of increased mortality in that patient population receiving the triple, so that receiving the checkpoint blocker we were seeing more toxicity. So this was a big disappointment to the myeloma community, because if you look at the phase 2 data, we do know that checkpoint blockade works in myeloma in combination with the IMiDs, and when we looked at the data yesterday, a lot of the toxicity noted in this two trials was immune-related toxicity. So I think this is a learning moment for all of us. You have to be cautious about when you combine drugs. You have to be careful, and you have to learn as to how to combine these drugs. And the other thing is understanding and knowing that drugs like checkpoint blockade, where toxicity doesn't happen immediately, toxicity happens 2, 3, 4, 5 weeks down the line. Understanding that, educating people about that is really important. The other thing I will add is, myeloma is a very different disease from solid tumors. So the solid tumor oncologists are very used to using checkpoint blockade. Most times their immune systems are fairly intact. In myeloma, that's not the case, and a lot of myeloma patients or patients with lymphoproliferative disease have an autoimmune kind of a disease, and I do think that gets triggered off. Does not mean we should not be using these drugs. I think we need to learn how to better use them, because we see amazing responses in a subset of patients. So I do think the next couple years is going to be a learning curve here, understanding these toxicities and combining them in the right direction, and educating the caregivers and our patients on recognizing these toxicities and treating them in a timely fashion is what's going to help. The last one which was presented was, actually a very interesting trial by Nina Shah, and this was work which she'd done in the lab at MD Anderson, and I really like this because this is an academic translation from the lab to the clinic. And all of us have always been focusing on the NK cell in myeloma, which is the natural killer cell. And if you think about it, we've been using IMiDs for years. So pomalidamide, lenalidomide, we've shown in preclinical studies that all of these increase your NK cell activity, and that does help control your myeloma. The other thing, with all the eloquent data with targeting SLAMF7, now SLAMF7 is a protein which is present on NK cells, and it allows myeloma to recognize those NK cells and activate those. So we do believe in using NK cells as a therapeutic strategy, as we've done with all of these targeted agents. What Nina did here was a very interesting trial, and I think it was more a proof of concept, and it was a different kind of a cellular therapy concept, where she took patients who had relapsed and transplanted them, but used an allogeneic product, a cord blood cell product, and the cord blood cell product was where they pulled out the NK cells and gave these NK cells back to the patients. Now obviously, to me this is exciting because it demonstrates feasibility of something we've been wanting to do. There's lots of questions there, the persistence of NK cells typically they don't persist for more than a week to 10 days, and that was what Nina saw. I think we need to do work on how these guys can persist. The other thing we need to try and identify is, this was done in the context of an autologous transplant, so it's really hard to tease out what those NK cells are doing in the context of high-dose melphalan and the auto transplant. But nonetheless, as a proof of concept, I thought it was, one step forward in the field of cellular therapy in myeloma.